So, thank you. I'm always happy to be here. And this is the second day and early morning hours. But I'm going to take my time for running it through like more like an academic program than really very immediately or trying to make any inspiring statement on that. I think we need to have a grasp of why we are interested and why this topic has become so important to us. In my brief presentation, or maybe not so brief, I would be covering 5 important objectives of understanding public financing, or 5 aspects of public financing, if you may. The first is what we are, in a very intuitive sense, engaged in. How do you raise more money for health? The second is of financial protection. How do you prevent people from spending more on health, though they need health more? This is a particular area of public financing that is very important and that has really come about to prominence in the last 2 decades. A third, because this sometimes gets forgotten by people working in financing, is improving access. Physical access to services itself is a problem. Another major aspect is of increasing the value of the money spent. That is, while we were talking of more money for health, we are also talking of more health for the money, more value for the money. How do you use efficiency is the ratio between how much you spend and how much you get out of it, so that for that same amount of expenditure, how can you maximize the public services that you get, the public benefits that you get. And fifth, in its own merit and as part of its own value, is the reduction of health inequities as a goal in itself. It is embedded in the other goals, but at some point it is a goal in itself. So I'm going to spend a few minutes on each one of these 5 aspects to give you an overview of what we need to know in public health financing. Broadly, the sources of financing are general revenue, general taxes, and social insurance. These are the main forms. You can add community insurance. It's too much of a oddity to really make the main grade. And then you have private insurance, which have 2 forms. Private financing has 2 forms. One of it is private insurance. That means you pay earlier in anticipation because you are paying for the risk. And then you have direct out-of-pocket expenditures. Broadly, if you categorize the pattern across nations, you can see there are some nations, which is the pointer there. Is there a pointer there? Yeah. There is a pointer there, but I think it doesn't work at that distance. It's okay. Don't worry. If you take the first square, it is public providers and public financing, where more than 75% of all the money that anybody spends on health is spent by the government. You would have it in the first square, public financing and public provisioning. Now, some of them may not be having that as their stated policy, but that would be in effect what is happening, that 75% of the public is publicly funded and publicly financed. For example, in Thailand, United Kingdom, Spain, private sector is quite allowed in a major way. But effectively, it is public financing and public provision of service that dominates. Whereas if you go to the next column, places like Germany, the Japanese, Canada, New Zealand, many of the providers are private providers. But government purchases services from them. Their prices are set, their package rates are this, and in some of them they are single payer systems, meaning out-of-pocket expenditures are not even allowed. All the purchasing is done. So the provider may be private, but he has to be contracted with the government and he would be purchased across terms which are negotiated. So this is private provisioning and public financing. Then you have where public provision but private financing. This is, for example, we have examples of this. We don't have a nation, fortunately, that works like this. Meaning, suppose you have a public hospital where the degree of user fees that you charge, cost recovery that you do, is enough to sustain that hospital, then you are in that particular category. There are very few, and where they are there, they can be quite working again, very inequity prone. But at some sense, there is no national system that works. But you have many which are private providers dominate and private finance dominates. So here you have, among high income countries, you have only one country, the United States of America, and you have most low and middle income countries, including India. In India, you have 30 to 40% public finance, but at some point this is it. So what you really require is eventually when we are moving from here into this, either of these things on that. When you talk of tax-based public financing, undoubtedly it is the most equitable. Why? Because taxes are collected inherently from different people according to different their ability to pay. And of course, taxation can be progressive or regressive, but we are assuming that you can have progressive taxation where the rich pay more taxes and the poor don't pay as much taxes. But at some point, remember, even the poor contribute a lot through indirect taxes. Every time they travel, they are paying tax on the petrol. And the sum total of taxation may be more from the poor than from the rich, and that would be a state of regressive taxation. Eventually, however, you need tax reform, which is a larger issue. But when we measure the extent of public financing, its adequacy in public financing, whether we have space to get more public financing, these questions relate to 4 parameters that it is interesting to know about. One that you are all familiar with is as proportion of the GDP. The National Health Policy says 2.5% of the GDP at least should be spent on health care, but currently we are spending 1.04%, etc. But the second is what proportion of the budget we should spend on health care. So currently we are spending 3.5 to 4%, but we should be spending 7 to 8% is a goal. Some people say 10% is a goal. So people would see the second one as more practical than the first one, because the first one is more dependent upon the economy, the second one on government finances. The third indicator relates the two. It relates the buoyancy of government financing as different from the buoyancy of the economy. It is what proportion of the total GDP is government expenditure. Remember that in India, in Tamil Nadu and all, it is about 14 to 17%. I don't know the exact figure. But in France, for example, or Sweden, for example, it could be 30 to 40% of GDP could be total government expenditure. So we think of them as private sector, capitalist, industrialist countries, but the proportion of public expenditure and public services in these advanced capitalist nations is far more than even in the best LMICs, 30 to 40%. Therefore, they have very high taxation rates. Almost 40 to 50% of the rich will go on taxation. And that is plowed back into services which are of a much more equity determined. So this is a third part of it. And finally, we are looking at what part of total health expenditure, how much people are being impoverished. The last is the useful thing. It is of all the money that is spent on health, what comes out of pocket. In this particular indicator, India is one of the worst in the world. There are only 10 other countries which are lower than India, and most of collapsed states with war economies. So we are at third. So in an average, if you, even US is 44 to 45%, and abroad the average is 75%. So at some point, what we are really saying is there's a lot of space to do. If we were to argue with the Tamil Nadu government or Mon Finances, we will look at these indicators and we will see where we are positioned regarding it, and we would be able to share. In India, there is another big issue, that there is a question of how the center-state relationships on taxation. Okay. And many of these people who are in health economics don't do this, but we really need to understand this particular dialogue much better. And we need to be able to leverage it. One issue is what has been raised as the issue of fiscal federalism. Who raises the taxes and what proportion of the taxes goes back to that state? So naturally, you cannot say a state like Bombay or Chennai, where a whole lot of the taxes are not state, city, should all go back to Bombay because they earned it. Because the needs of equity mean that the sources in which taxes are raised are not necessarily the place which is spent. But it does lead to a question of how much the state gets and how much autonomy the state has to raise its resources where required. If the center takes over all the point in raising resources and in allocation of resources, how can there be any meaning federalism? So there is one issue, a large issue of fiscal federalism, and within that, in the health sector, is the transfer of central resources for the health sector, which comes through central programs, disease surveillance, digital mission, where they pay everything, centrally sponsored programs, where they distribute the central fund to the states in a formula they have, which is both population with some weightage for underdevelopment. And then you have the population adjusted for underdevelopment, and then the finance commission transfers. So that's a finance commission, is a constitutional institution. Its job is to see what part of centrally collected taxes are allocated to states. So in fact, the health people should actually have a good sense of this if you are going to really make a case for more finances on this. The other main avenue, which to my dismay we have handled very underplayed, is the social insurance, where mandatory contribution of employer and employee. In a sense, it's surprising we don't talk of it, because as government servants, what we have is actually a form of social insurance. And all the organized sector is covered by this. So countries which are mainly got more than 80-90% of their workforce in the organized sector will prefer social insurance modes. But where a lot of them are self-employed or unemployed or not, you really don't have that option. India still has a ESI, an act that was passed even before the Indian Constitution was adopted, but by independent India. Okay, it was one of the first acts, and it's a brilliant act as acts go. You will not find many acts in the subsequent period which are as brilliant. And currently the employer pays 3.25% and the worker pays 0.75%. And it offers perhaps the most comprehensive health benefits in the world, plus other 8 social protections that are required. It covers close to 13 crore population, which is a substantial population out of 130 crores. And can you believe it? It has more than 1.16 lakh crore surplus. More than 1.16 lakh crore surplus budget which they invest. In fact, I saw that 2021 report, and one of their achievements is that earlier they were getting 2.25% on that saving, now they are getting 6.25%. My God, this is of the money that they have in the bank and that they have not spent. I didn't see, it's good that they are not wasting them, but this is a particular issue, and we have not really looked into this particular diversion at all. Now I just want to take you to the second of my themes. What is the issue of financial protection? Why? Why do we talk? We don't talk of financial protection for transport, for tourism. We don't talk of it, even in a certain extent we do for food, but we don't talk of it for clothing or housing. Why is financial protection so important in healthcare? Because healthcare is a commodity unlike any other commodity. If I am going to buy a mobile phone or telecom, I sort of know whether I need it and what use I am going to have of it and when I am going to use it. But if I have to prepare for illness, I don't know when I will fall ill to save for it and what I will fall ill with. I am completely uncertain in my ability in the market purchase. Housing, I can plan for housing 10 years ahead or know that I am not planning, or I can't do this for that. Similarly, even the provider cannot guarantee healthcare. If I go to a hotel room and I've booked it, if he doesn't give me the hotel room, I'm going to get angry with him. But I go to a doctor, I cannot be assured of cure. I have to pay on the basis of trust that he has done what he has and I still died. I mean, to put a point on it. At some point, you have to actually, the trust is of a very high order, an unlikely high order for any other thing, because you are not sure of the. If I buy a mobile phone and it doesn't work, I'm not going to be very happy with the thing. I'm going to demand my money back. But if I don't get well, I don't demand my money back from my doctor on that. In some sense, it's an entirely different. And there is information asymmetry. I can't decide whether a normal delivery is needed or whether a cesarean section is needed. And then there is a non-alignment of incentives. You know what it means is, if there is somewhere the interest of the person producing the product to serve the customer's true needs. So if a person says, I can only pay 5,000 rupees for a hotel room, they won't offer him a 10,000 room. They'll offer him very good options in the 5,000 range. And therefore, the customer's interest, if somebody creates budget hotels, he makes a profit. But here, if he needs a normal delivery or a thing, or the thyroid nodule can be ignored or operated, there is the interest of the provider will be on providing care which is profitable, does not necessarily mean that is the care that is best. So somehow the clinical decision that the doctor makes has to be ring-fenced from considerations of monetary gain or loss. That remains a challenge. And finally, it is professional power. In Tamil, as we say, if a patient talks too much, we say, nee doctora, na doctora. You don't have a hotel manager say that to you, no? You don't have a mobile operator say that to you, no? Only a doctor can say, nee doctora, na doctora. And that is enough to shut everybody's mouth up on that. And that is the reason why the purchaser cannot be the powerless patient. It has to be the government on your behalf, or intermediary institutions which don't really work. So, the majority of healthcare is currently purchased when people go to a person and pays the doctor on each visit on the. This is the worst possible way of payment in the world. Out-of-pocket expenditure on a fee-for-service basis is the worst form of payment, and that dominates, promotes irrational and excessive supply, removes the political voice from the public sector, very iniquitous, major source of impoverishment. Why not voluntary insurance? Why not buy? So many good products are there, Bajaj Allianz, Apollo, Munich, etc. You know, insurance as a business has a different logic. I'm not going to go into detail here, but really, if I am a businessman who has invested in an insurance company, the best way I can do is to insure more and more the people who need it less and less. And if this fellow is likely to need hospitalization more, better find a rule to leave him out. Or better, if this is causing the greatest amount of cases, then better to somehow exclude it. I'm worried about such things in the CMCHIS also. You eventually have to be worried that at some point, the logic of private voluntary insurance, what makes for good business, is not necessarily what makes for good public health. And that is something that we really, therefore, move away from. Okay. So, what has Tamil Nadu done? What is Tamil Nadu's architecture to achieving it? The architecture is largely the provision of free. It's not free in that sense. It is free, cashless at the point of delivery to the patient. It is prepaid in the form of taxes. So, you can say tax-based public health services all outpatient care and over 90% of all secondary and tertiary care, financial protection is only through public services. It is supplemented by purchase of care from private sector through publicly funded insurance programs, example CMCHIS. Okay, basically the CMCHIS supplements it. And then you have contracting in of private service. We don't have too much hospital contracts or health facility contracting, but we do have, for example, 108 services and ancillaries that are contracted in over this. There is, of course, a problem of informal rationing care. This free care in the public service and in CMCHIS, in fact, it is not universal because we are able to provide for only so much and not everything on this. When we look at CMCHIS as a form of public financing, so everybody talks of government financing and CMCHIS. CMCHIS is a form of government financing. It is not something other. It is another route of public financing. About 50% of the funds go to public providers, and public providers use it as a purchase of consumables. So while I was on this committee, I kept asking every facility, why not just increase your budget? Why give it to you as insurance? And to my surprise, everybody strongly said, no, that would be fatal to the program. In some sense, it has to come this way. And the reason they said there's a whole lot of inefficiency in line item budget. Though small, it tops up, increases outputs on already. So you have built medical colleges, you have built hospitals, you have put specialists. But to provide services, this top up that provides a limit of consumables and this makes a huge difference in making sunk investments speak up in terms of a higher output in terms of product. It also stabilizes market in the private sector, and where public sector capacity is overrun, it can supplement it by purchases from the private sector, though in some sense this is an issue. It does not do some of the traditional things that insurance is supposed to do, but that we saw is the logic of private voluntary insurance. But this is a different logic. Increased access is investment in infrastructure and human resources and supplemented by purchase. Purchase, one of the theories of insurance is, okay, government service is not there. We can then purchase from private sector and support the gap. That's an expectation. It doesn't quite happen. Because usually where the government service is not there, the private sector is also not there. And if I may tongue-in-cheek add, the first private service is supposed to likely to be the private practice of the government doctor. And once the government doctor comes, all the medical shops open up and slowly it builds up. Second, even if there are private sector units there, they don't provide the services that public sector is not providing. So if you want, okay, these services are not available over here, though you go in practice, you find the range of services they provide are very similar. So though purchases can potentially supplement, in practice their supplementation is very limited. We can improve that, but it's still to be done. Working with public-private partnerships, we see that at some point there are good successes. But there are, in terms of outsourcing, PHCs, district hospitals, voucher schemes, some of these have not been this. I have used this from an earlier period on this, you can see that. Now, coming to the fourth theme, ensuring more value for the money, more health for the money. One fundamental principle is to invest more on primary health care. And I think from the Directorate of Public Health, how many more minutes you will give me? 5? Okay. Investing more on comprehensive primary health care is the important thing. Primary health care is value for money. That doesn't mean you put bank investment into it. What it really means is public investment in it counts on a different way. You must remember, efficiency in the private sector is a higher rate of return on investment. Primary care is unlikely to do that. Efficiency in the public sector is more value for the money. For 100 crores, how much health outcomes can I gain? That 100 crores invested in primary care will give you more health outcomes than you will get in investing in hospitals. And therefore, one of the best ways of spending public money is on primary health care, but more comprehensive. and prioritizing interventions within that which give greater benefits. Then contracting in certain services where you're not the expert to provide improved payment mechanisms and preventing corruption and leakages on this. That's what we always call the elephant in the room, the corruption angle on that. Now, payment to provider, there are techniques. One of the problems of public financing as we know it in India today is the problem of the line item budget and its rigidity. Every item, every training program is fixed, every HR is fixed. You have no flexibility at all to spend on that. And that is the reason why CMCHS has played a big benefit, because it allows an untied fund over there within certain rules to be useful on that. But there are inefficiencies. Some places like Thailand goes for case mixed adjusted admissions, meaning last year so many patients we saw, so much cases we saw, the total value of that was this much, we give you that budget for this year's expenditure. We already do that for TNMSC. It's not such a new concept here, but we can do that for all of services also, because otherwise one CHC, one upgraded PHC which is seeing 100 patients per day and another which is seeing 1000 per day, one that is covering 10,000 population and another that is covering 2 lakh, all get the same money, which is a whole lot of allocative inefficiencies on that. And then this is the capitation fee approach. A subcenter is paid according to the number of population it serves, not a fixed amount per subcenter, irrespective of the population served on that. And each one of these has problems. I don't have advantages. There's no one solution, but you need to get a right combination of this. Let me take an issue on corruption. Big problem in public health systems and in public financing. You go ask the finance secretary why he doesn't give money, very often he'll say, oh, how am I sure it is spent? Like we are good public health people, you should see corruption also as a public health problem. And in some sense that costs lives, and in some sense prevention is better than cure. And you should look at systems that provide it rather than catch the guy after the event. You know, when they put CCTV cameras, they put a big board, this place is surrounded by CCTV cameras. What does it mean? It's not, if they are wanting to catch a person, they'll put a camera and not tell anybody, so that when that fellow thieves, you can catch him. But this is not meant to actually catch him. This is meant to frighten the thief away. So the careless thief, at least, who is avoiding it, can be frightened. So in all, corruption also requires a system to operate regularly. At some point, if you take in each one of these, the Tamil Nadu government has certain innovations by which this problem, I mean, it may never go away, but it is reduced in a fine way, and one needs to look into each one of these. Then grievance redressal mechanisms and improved vigilance. These are always part of the discussion. Being able to reduce finance is one of the fact that you have less, what is called in World Bank language, fiduciary risk. So they have all these beautiful words for it, rent seeking. They have, I was wondering putting the word, but then I said, people won't understand. We must call a spade a spade. And we really get back on that. You have much greater credibility for getting public financing on that. Then, of course, there is this new area that has opened up. A new department, the equivalent power of the Directorate General of Health Services had opened under the DHR, which is on health technology assessment. Only day before I went for a review meeting of that. And it's a choice of technology and defining standard treatment, also reducing wasteful care, not buying a very costly equipment where for the level of service you provide a equipment with lesser specification will do. Area where NHSRC has helped the country greatly by showing specifications area. And when a new technology, okay, the present Sali's hemoglobinometer doesn't work, which is the better hemoglobiner I go to? It will be costlier, but it will be easier. At some point, what cost can I go for? These sort of questions are handled by health technology assessment on that. And also what to prioritize, what to include in the package, what to exclude. Whenever you include something, something gets displaced. This is a 1,200 crore budget. If I put something in for the CMCHS, if I include something, something will get displaced. Do I include it? Is it worth value for money? Should I put heart transplants when the life survival is only 3 to 4 months, when there are other things which would pay for an equivalent amount of much larger amount? So these are questions that are faced in this branch of public financing, which is important. I think Tamil Nadu should build its own capacity to do these studies. It has some capacity in the National Institute of Tuberculosis and in the DHR, but you should have mainstream this capacity. Finally, equity is not aligned to efficiency. The distribution of healthcare services as per population and geography is necessary, but it is not sufficient. Just because I've seen this problem in Tamil Nadu leadership, I'm an old friend of Tamil Nadu leadership. I say it as a friend, can be in denial of this because say, look, we have created all the hospitals and it's free and we allow people to come in. There are no barriers. But there are demand side barriers and you need affirmative action and additional resources to reach marginalized population. Even in CMCHS enrollment, the last quintile, the poorest quintile can have a lower enrollment. At some point, you have to have proactive measures to reach this population because just the opening of a clinic does not solve the problem on that. You know, one classical example which we just have put into the report is when a homeless, most destitute person comes to a public hospital, simply because there is no attender for him to stay. And our system implicitly assumes that relatives of the patient are acting as para-nurses. That's our system. We expect the attendant to be there to take care of much of the dirty business around the patient. And that particular area, if you don't have, there is a reluctance to admit patients who don't go bring an attender and come. It could be a common reason for sending. But in other places, you would have from CMCHS fund some volunteers available who will volunteer to stay 2 or 3 days and be an assistant to a patient without an assistant for a payment, for a per day payment on that. That sort of affirmative action to, otherwise the homeless, the destitute, people who have children at small, women with small children, they can't just come and stay. In some places in France, you would even have a caretaker sent to the home to take care of the children. That may be even, we must think of what it really means to assess the marginalized equity. So public, that may not be efficient in a very way, but at some point the demands of equity require those sort of things. There is right for a right to health care movement. I know that many people will be unhappy, worried about this concern. But Tamil Nadu has made a lot of investment in public services. If you are going to safeguard that investment in public services, it must become your law. If you don't do that, you are likely to have pressures that are adverse and your next generation will not have the benefits that you have. The second reason is safeguarding primary health.
Sir hold his MBBS degree
because eventually you cannot enforce your entitlement in the private unit.
And he has also completed his
degree. Private sector has a different logic.
And
you can in the public hospital.
From
and
Indian
your registration in the primary sector is like you are a patient of it is case where your entitlement is delivered. So the whole importance of primary care is always has to reconcile before from a legal entitlement that comes because without everybody having an entitled access to a primary care, and registration in the primary care being a gateway to the entire range of services, you can't have a right to it. Third, established criteria for infrastructure and human resources for institutions that safeguard efficiency. I mean things like DNMSC only and some set of a law, but we need to put it and establish a principle that only. So, Anand is a law 52 of the NHSO Act, which says that every provider is entitled to be reimbursed for the services that are provided. So if you have a private sector volunteers to come under the act, then he also will be reimbursed. But the reimbursement is what it called at marginal cost. It's not the full profitable cost. But at that point, there is an entitlement to reimburse, and that is important because your budgets have to move flexibly according to the amount of care that last year you have provided. So if you have a much greater outpatient, more cancer patients, I was just telling the director that your cancer rate of discovery of cancer is 3 times the expected rate. That's because the expected rate is some global average and needs to be changed. But you're obviously having a lot of cancer patients. It's obviously going to take a lot of budget. It's obviously not being managed in the private sector very adequately. It manages few patients at high rate of returns rather than many patients at low rate of return. That's the model that works for private sector. So at some point you have to expand, but you need a budget. So there has to be a legal commitment that the budget will have to flow. If you just say that we need 10% of the budget, it's difficult to get finance to understand. But to say that you are providing these services and these services must be paid for, it is much easier to. And finally, it ensures equity in public finance, that no one is left behind. So these principles built into the law at some point at an expression ensures progress towards health equity and universal health coverage. I have some of these in one book that I have been particularly taking around, this Right to Healthcare. This is a book written for Tamil Nadu. I have shared it with a number of the officers, but you may want to look at this. This has been something that sets out the problems also, sets out the challenges, but the frontier, you have called this public health the future. Sir, this is something that you must really take on board as the future. Thank you. Okay.
Thank you, sir. Thank you for your valuable insights and giving the public-private financing across the nations and touching upon the importance of social insurance, emphasized health as a social good, and you have touched upon the advances in public-private partnership models. And thank you. You have enlightened us with your presentation. Now the house is open for questions.
Sir, good morning. Sir, good morning. Thanks for the presentation. Sir, I have 3 questions. First is related to health financing. So recently we have found that, since we are in field, we find that the financing for health is more dependent on national health mission. For simple expenses at sub-centers level or at PHC level, we are waiting for funds from NHM, which is provided by Government of India. So how should we take it? Either the state government has decreased its funding, or the system is becoming more dependent on the Government of India funds for functioning. This is being asked in context when we are talking about decentralization and which is proving to be more successful. We are more becoming dependent on the central government funds. The next is regarding few programs from universal health coverage. I will take an example. One of the program under UHC is eSanjeevani. The eSanjeevani, the teleconsultation, telemedicine, which was started during COVID time, and still the program is continuing, and we are expecting results from that. So that was started at the time when there were limited access to medical facilities, and this is being still continued and financed today. So this is also expected on similar lines and results across the states in India, where the health infrastructure differs in each state. So again, the health programs under UHC is becoming centralized, and the results are also expected to be uniform across the country.
So your comments on that. And finally, the third question, the taxation on products like, my question is based on our DPHS discussion during past 2 days. The taxation on alcohol, tobacco, sugar products, all this failed to turn into the health's coffin. These were put into the general expenses and never served health as a specific point. So your comments on that. Thank you, sir.
This NHM question is a bit of a dynamic question. One point, the state has an entitlement to get funds from the center. It's not a donation that they are doing to you. It's a part of the taxes that have been raised from you, especially in Tamil Nadu, which is a tax surplus state. If you forego that, you lose that money. So even in the CMCHS, I keep asking, why are you going after that 442 crores? The point is, if the center has allocated that money to you, why should you forego it? It's the people's money. How can you say we don't need it? Second, even within the NHM, 40% is paid for by the state. So when you say NHM budget, there is a pool on it which is the state budget. Now, should we wait for that for every initiative? We should not, but actually you have to not pose it against getting NHM money. There are priorities, and no program should be so flimsy that it depends upon an uncertain budgetary allocation every year. So at some point, if there is an assurance of this, they can't withdraw it or should not withdraw it, and you should have the backup provision for it, and therefore that part of it is very important. But there will be a concern in the officers, then the center says you are managing it, you go ahead and manage and stop giving the money. Then already the state requires a lot of support from the center, which it is not getting in proportion, and therefore that's the issue. So that is a classical issue of the center-state relationships in an area which is the state subject, and how the state must exercise its federal rights within that. It's partly a political question, but partly at the level of policy it has to be taken up. So and you need not follow the dictates of the NHM center. That's sort of easier said than done. But on the other hand, they are guidelines, they are not rules, and you will have to explain your alternatives in a convincing way. But then stick to your alternatives on that and be able to do that. You need a high quality of intervention to do that, but you have to be able to explain your alternatives. This is broadly on that. This e-Sanjeevani is a real good example. And remember, I'm not the government, I'm free to speak and I use that freedom well. It's a good example of how you can draw defeat from the jaws of victory. How you can make a very good program into something which is a caricature of it. e-Sanjeevani is the introduction of telemedicine on scale. What's your problem with telemedicine on scale? Whenever you have a problem, you have a skin disease that the primary care certain person doesn't know, he contacts the nearest dermatologist and gets an opinion and treats it. That's good. That's e-Sanjeevani. Unfortunately, you in your mind, you are linking e-Sanjeevani to presenting 10 consultation reports per day. Irrespective of whether you needed the consultation or what you need the consultation, I know in many states, not Tamil Nadu is very good, doesn't do that. The person doing that will say, you write that report also, because I have just got to tick in the box that I have done 10 consultations. And that is not the spirit or sense of e-Sanjeevani. But don't throw out the baby with the bathwater just because some officer got into his mind. I can't even blame that very completely. We don't start doing it till we have a target. Not a good thing, but that's the way we have got used to it. But at one point at least, they above should change or you should change and say, hey, this target is not important. The sense is, there should be real problems that are brought to the telemedicine portfolio for which the big requirement is not that equipment. Because you can do it even on the mobile, not that software, which is an irrelevant piece. But the two people at the two ends relate to each other, they feel for each other, like it is the relationship between a professor on a ward round and his intern or his junior assistant professor. He has that intern and the professor says, yes, pa, you have a problem. What is the case? Present the case to me. This is the solution, and he gives the professor's advice on that. I mean, I don't blame the IAS for not understanding it. That's why they are the IAS, but we as doctors should do better. I mean, this is a typical problem that comes in because when Indian Administrative Service takes over running clinical function, they don't have a clue as to the spirit of it. I mean, there are many good things, right? Because you gave the space in policy, that's why you are in this situation. So I'm not going to be all at support of doctors. But remember, at some point, you have to extract the good sense out of that program and put it in place. I enjoy saying this to IAS officers. There's no sunshine telling it to you because you will only applaud, but you must actually get. But that's important that you speak out. So e-Sanjeevani is a good understanding of telemedicine which is being inappropriately used. Telemedicine should be used for continuity of care, and the central thing in it, the heart of it, is the human relationship between the specialist and his team. You get that right, you will get everything. So how do? You may not need a software. What you may need is a party in the evening where they meet each other and shake each other, or a so-called academic program, which often is a party disguised. And when you have a program where you can meet each other and they can know where they are sending to, what they are sending for. And some of these are so unproductive. Most of them, where any meaningful thing, they'll say, send the patient there. So you have not even optimized what you would use e-medicine for and what you would not use for, because you are just fulfilling targets. Think that through. Think where you need, how you will make sure the specialist required is available on the opposite side. You may need to fix up your own timings between yourself. In each place it may be a different timing. So don't waste that opportunity. But yeah, I agree with your problem. And the third question was, I think I should close quickly on that.
So the taxation on tobacco, alcohol, and all those things doesn't turn into the health problem.
I'm not a great fan of that. But if the taxes is coming here, I'm not going to be a person actively opposing it either. The point is, it becomes dependent upon more and more tobacco use and alcohol use when you have a public health goal of limiting that use. And beyond a point, taxation does not reduce consumption. There is a critical line where it does, but beyond a point it does not. So one has to be careful about that weapon. In fact, when the national health policy was drafted, many of us didn't recommend it, but at some point it came into the policy document. So people, I mean, one argument is, anyway the tax is being collected, we should use at least some part of it. Say if one formula is 30% of the taxes collected should be given as a cess, something like that. You can do that, but don't make your health service dependent upon the abuse of preventive measures on that. That's the larger lesson. You know, yeah, there's a thing we see about one tobacco industrialist in Madhya Pradesh who was told that because of his people smoking so much tobacco, there was an increase in lung cancer. So his immediate response is, good, then I'll start a cancer hospital. You know, and that was the depth of loss of ethics, and that in some sense you actually see in sickness and opportunity. There is an ethical problem here. You must be careful about treading this domain. It calls for a wise deliberation, a consensus that is transient, how it will be replaced by a larger, some philosophy involved also. You know, all these public health issues are great issues of understanding philosophy, understanding life world, understanding systems. So I think it is thrilling to be young and in Tamil Nadu's public health system. You have a great opportunity ahead of you, but be creative, for heaven's sake. You are to advise officers on what should be done, but not and implement it creatively. And I am so happy that you have created a conference like this and a platform where people can lean back, reflect, think about these issues and take it forward.
Thank you for sharing your expert vision, sir. Now I cordially invite Dr. C. Shekhar, Additional Director of Public Health and Preventive Medicine, Universal Health Coverage, to felicitate the speaker on behalf of DPH ICON 2023.
একটা ভুল কন্টাক্ট